Thenar muscle atrophy is a condition characterized by the wasting away of the muscles at the base of the thumb, known as the thenar muscles. These muscles play a crucial role in thumb movement and grip strength. Atrophy in this region often leads to noticeable flattening of the thenar eminence and can significantly impact hand function. The most common cause is carpal tunnel syndrome, but other neurological or musculoskeletal disorders may also be responsible. In this video, we'll explore the clinical presentation, diagnostic approaches, and key findings from a large study of 197 patients, providing a comprehensive understanding of thenar muscle atrophy. Thenar muscles consist of three main components: the abductor pollicis brevis (APB), ponens pollicis (OP), and flexor pollicis brevis (FPB). These muscles are located on the radial side of the palm and are essential for thumb opposition, pinching, and fine motor tasks. The APB and OP are innervated by the recurrent branch of the median nerve, while the FPB has dual innervation from both the median and ulnar nerves. Understanding this anatomy is vital for diagnosing the underlying cause of thenar atrophy, as different patterns of muscle involvement can point to specific nerve injuries or syndromes. Carpal tunnel syndrome is the leading cause of thenar muscle atrophy. Several other conditions can also result in this problem. These include injury to the recurrent motor branch of the median nerve, proximal median nerve neuropathy, plexopathies, cervical radiculopathies at C8 or T1, ventral horn cell disorders, diffuse atrophy, and even congenital anomalies. Inflammatory or autoimmune diseases such as Guillain-Barré syndrome may also play a role. Recognizing the broad range of possible causes is essential for accurate diagnosis and effective management. Patients with thenar muscle atrophy typically present with a visible flattening of the thenar eminence, weakness in thumb movements, and often sensory loss in the median nerve distribution. The degree of atrophy can be total, affecting all three thenar muscles, or partial, involving only one or two. In some cases, the flexor pollicis brevis muscle may appear hypertrophic, compensating for the loss of other muscles. Careful clinical examination is crucial to distinguish between these patterns and to assess for associated symptoms such as pain, swelling, or deformities. Thenar atrophy can be classified into total and partial types. Total atrophy involves all three thenar muscles, resulting in a completely flat thenar eminence. Partial atrophy, on the other hand, affects only the APB and OP muscles, with the FPB muscle often remaining intact or even hypertrophic. This distinction is important because it can provide clues about the underlying nerve involvement and guide further diagnostic testing. Understanding of thenar muscle atrophy has evolved over time. Early observations in the 20th century linked partial thenar atrophy to occupational trauma and slow progressive nerve damage. Notable cases described by Hunt and Wartenberg highlighted the importance of careful clinical assessment and the need to consider a wide range of differential diagnoses, including neurological and musculoskeletal conditions. These historical insights laid the groundwork for modern diagnostic approaches. Carpal tunnel syndrome (CTS) is the most frequent cause of thenar muscle atrophy, especially in severe or long-standing cases. The incidence of thenar atrophy in CTS patients ranges from 5% to as high as 100% in severe cases. While the presence of atrophy is highly specific for CTS, its sensitivity is relatively low. Electrodiagnostic studies are often used to confirm the diagnosis and assess the severity of nerve involvement. Electrodiagnostic (EDX) studies, including nerve conduction velocity and electromyography, are essential tools for evaluating thenar muscle atrophy. These tests help detect abnormalities in the median nerve, such as axonal loss or severe entrapment. However, in some cases, especially with advanced atrophy, EDX findings may be inconclusive due to absent muscle action potentials. This highlights the need for complementary diagnostic methods. Ultrasound (US) is a non-invasive, rapid, and cost-effective imaging technique that provides valuable information about the median nerve and thenar muscles. It allows for dynamic and functional assessment, helping to visualize muscle echogenicity and architecture. US is particularly useful when EDX studies are inconclusive, as it can confirm the presence and extent of muscle atrophy and help differentiate between total and partial form. Comprehensive study was conducted involving 197 patients and 226 hands with thenar muscle atrophy. All patients underwent clinical examination, electrodiagnostic studies, and ultrasound imaging. The study aimed to classify the types of atrophy, assess the severity of nerve involvement, and evaluate the diagnostic value of EDX in US in determining the underlying cause of thenar muscle atrophy. The patient group had a mean age of nearly 69 years, with an even split between males and females. Thenar atrophy was more common on the right hand and often corresponded to the dominant hand. A significant portion of patients had diabetes, and a small percentage had a history of carpal tunnel release surgery. These demographic details help contextualize the findings and highlight risk factors for developing thenar muscle atrophy. Among the 226 hands examined, partial thenar atrophy was much more common than total atrophy. In partial cases, the APB and OP muscles were weak, while the FPB muscle often remained prominent or even hypertrophic. Sensory loss was present in the vast majority of cases, further supporting the diagnosis of median nerve involvement. These patterns provide important clues for clinicians during assessment. Clinical and ultrasound images provide a clear visual representation of both total and partial thenar atrophy. In total atrophy, all thenar muscles are wasted, resulting in a flat palm base. In partial atrophy, the FPB muscle stands out against the atrophic APB and OP muscles. These images are invaluable for both diagnosis and patient education. Some patients, partial thenar atrophy is accompanied by a prominent or hypertrophic flexor pollicis brevis muscle. This compensatory hypertrophy occurs as the FPB muscle takes on more functional load due to the loss of the APB and OP muscles. Ultrasound imaging confirms these findings, showing a distinct bulge of the FPB muscle amidst the atrophic thenar region. Electrodiagnostic studies revealed that nearly all hands with thenar atrophy showed severe median nerve entrapment at the carpal tunnel. Only a small number of cases had mild or moderate findings. In rare instances, atrophy was due to other causes, such as rheumatoid arthritis or cervical radiculopathy. These results underscore the strong association between severe CTS and thenar muscle atrophy. Significant proportion of hands showed absent compound muscle action potentials, CMAPs, and sensory nerve action potentials, SNAPs, in the affected muscles. This absence is a hallmark of severe nerve damage and advanced atrophy. In some cases, alternative recording sites such as the second lumbrical muscle were used to improve diagnostic accuracy. In addition to median nerve pathology, some patients also exhibited signs of ulnar nerve neuropathy. This coexisting condition can influence the pattern of thenar atrophy, sometimes leading to total atrophy if both nerve supplies to the FPB muscle are compromised. Recognizing dual nerve involvement is important for accurate diagnosis and management. Ultrasound studies revealed that nearly all affected hands had hyperechoic changes in the APB and OP muscles, indicating muscle degeneration. The FPB muscle was hyperechoic in a smaller subset, usually in cases of total atrophy. The cross-sectional area of the median nerve was also measured, providing additional diagnostic information. Heckmeck grading scale is used to assess muscle echogenicity and architecture on ultrasound. Grades range from 1 normal to 4 severe degeneration. In this study, most hands had a Heckmeck grade of 3 or 4, indicating moderate to severe muscle degeneration. This scale provides a standardized way to quantify the extent of atrophy and track disease progression. Statistical analysis showed no significant correlation between the severity of carpal tunnel syndrome and the Heckmeck score in this cohort. This may be due to the overwhelming majority of patients presenting with severe CTS. Nonetheless, both EDX and US findings remain essential for comprehensive assessment. Thorough clinical assessment is the foundation of diagnosing thenar muscle atrophy. This includes evaluating muscle strength, sensory function, and the presence of atrophy in other hand muscles. Identifying whether the atrophy is total or partial, and correlating these findings with nerve conduction studies and ultrasound helps pinpoint the underlying cause and guides treatment decisions. Distinguishing between different causes of thenar atrophy is critical. For example, atrophy due to CTS typically spares the FPB muscle, while combined median and ulnar nerve involvement leads to total atrophy. Other causes such as cervical radiculopathy or diffuse atrophy have distinct clinical and electrodiagnostic profiles. A systematic approach ensures accurate diagnosis and avoids unnecessary intervention. Etal electromyography (EMG) is a valuable tool for assessing the extent of motor unit loss and denervation in the thenar muscles. By recording from multiple muscles, clinicians can differentiate between distal and proximal nerve lesions, as well as rule out more widespread neuromuscular disorders. EMG findings complement nerve conduction studies and ultrasound imaging. When electrodiagnostic studies are inconclusive, ultrasound becomes especially important. It can confirm the presence of muscle atrophy, assess the cross-sectional area of the median nerve, and provide real-time visualization of muscle architecture. This makes ultrasound an indispensable tool in the diagnostic workup of thenar muscle atrophy. Identifying the underlying cause of thenar muscle atrophy is essential for guiding treatment. In cases of CTS, cervical decompression may be indicated, especially when severe atrophy and nerve dysfunction are present. For other causes such as inflammatory or degenerative conditions, targeted therapies are required. Early diagnosis and intervention can help preserve hand function and improve outcomes. This large study provides valuable insights into the clinical, electrodiagnostic, and ultrasound features of thenar muscle atrophy. Its strengths include a sizable patient cohort and standardized assessment protocols. However, limitations such as its retrospective design and lack of follow-up data should be considered when interpreting the findings. Future research with prospective designs and independent evaluations is warranted. Summary: thenar muscle atrophy is most commonly caused by severe carpal tunnel syndrome, but other neurological and musculoskeletal conditions must be considered. Electrodiagnostic studies and ultrasound imaging are complementary tools that help confirm the diagnosis and guide management. Recognizing the patterns of atrophy and associated nerve involvement is essential for effective patient care. Advancements in imaging and electrodiagnostic technology continue to improve our ability to diagnose and manage thenar muscle atrophy. Emerging techniques, such as shear wave elastography and refined grading scales, offer more precise assessments of muscle health. Ongoing research will further clarify the best approaches for early detection and intervention. Educating patients about the signs and symptoms of thenar muscle atrophy, especially those at risk for carpal tunnel syndrome, is crucial. Early recognition and prompt medical evaluation can prevent progression to severe atrophy and permanent hand dysfunction. Empowering patients with knowledge supports better health outcomes and encourages timely intervention. Thenar muscle atrophy is a significant clinical finding that warrants thorough evaluation. By combining clinical examination, electrodiagnostic studies, and ultrasound imaging, clinicians can accurately diagnose the underlying cause and tailor treatment accordingly. The insights from this large patient cohort reinforce the importance of a multidisciplinary approach and highlight the value of early detection in preserving hand function.